So the key learning objectives of these sessions are: what is the research question? So what is my topic? And how can I answer, once I have this topic, how can I answer the research question? And then what do I need? What means do I need to conduct a clinical study finally? Well, first step usually is brainstorming how to find a research question. So you have an academic center, you want to publish, you want to do studies. And the first thing is to do brainstorming. And the usual ways that there's some long established practice is the misconception what could be done better. So something which you always do, but you always feel that that does not really work very well. And the second thing is, are there conflicting views? So if you go to morning rounds and 3 colleagues say, well, let's do it this way, and 3 colleagues say, let's do it the other way, then there may be not the perfect way, obviously, and this may also be a chance to perform a study. There may be also some geographical variations. So, for example, doctors in Japan do it differently than in the US or in Europe. So maybe there may be something you want to compare. And then you first time have your idea and don't go immediately into doing your study, but you should challenge your idea. And the first thing is, do I really want to answer the question? So I'm really motivated. Maybe a good question, but maybe it's not my question because it's not the topic I'm interested in. Does it have an implication for patient care? So is it clinically relevant, or it's a nice question, an academic question, but no one will be really interested in the answer of this question? Did no one answer the question so far? This is sometimes tricky, because at least if someone answered this question already, you need to find a new aspect, you need a longer duration of the therapy, or a different patient group, or you have to put some novelty into your project. You cannot do the same thing once more. And is there also a possibility to answer the question? So many questions are very interesting, but there's no way to answer them. One reason may be that ethically it's not possible to compare things. So, for example, you need to have equipoise, which means you have 2 different treatment options and you do not know which treatment option is the better one. So only in this case you can really randomize patient to one of the treatment options. And the last thing is, do I have the means to answer the question, the resources? This is not only financial, but also technical. Do you have enough patients? Do you have dedicated staff? Do you also have the expertise, so will really the field believe you if you are going to answer this question? So usually you discard 9 out of 10 ideas, and don't worry, there are enough open research questions. So don't go into the first idea, but really try to challenge the idea. Well, who may help you in this way to find out whether your ideas were following it further? It's the daily practice, of course. So you check in daily practice, well, what would change if I can answer this question? You can ask your senior researchers in your institution. Of course, the literature research is very important, including guidelines, identifying open questions. If there's already a publication with a similar hypothesis, what would be the novelty of my study question? So if it really fits into the field, what can I learn from the published studies, for example, about methods they used? And of course, you should look at trial registers like the clinicaltrials.gov or WHO website. And here we have an example. For example, there's ESC guidelines on aortic disease, and the ESC guidelines identify these major gaps in evidence and tell you where you should really put your efforts into. And actually there are many gaps. For example, about aortic disease, they say we need more epidemiologic data. They say we need to know about the implantation efficacy of aortic centers in Europe. We should evaluate the value of biomarkers. We need more data about accuracy and reproducibility of aortic measurements. We need to know about the relationship between aortic size and outcome. We need data for female patients. We do not have data about the evidence of medical therapy. So there are really many open research questions. You really should go into the guidelines and really think about these open gaps. Well, there's also the other way how you may end up with irrelevant results. That's the usual way of fishing expeditions. So you search for a significant association in existing database without a research question. It's fine to use existing databases. This is very efficient. Of course, this makes a lot of sense, but you should first have an idea and then check your idea in the database and not just scroll the database for any significance without knowing what it means. And also a question that is easy to answer but is not of interest for anyone. So if you already know the solution before you start, it's probably not worth to do the study. Well, once you have your idea, your challenged idea, you're sure you want to answer this idea, you have to translate it into a research question, aims and sub-aims. So what is the exact research question? That's a hypothesis, which means you need some time, a definition of time, of place and patient. What are the aims and what are the sub-aims? And here we have an example. For example, if you think my idea is green apples keep the doctor away, okay, nice idea, but you have to translate this into a research question. So it could be, for example, do green apples prevent myocardial infarction? And your aim may be whether green apple per day, so you define the duration and the amount prevents myocardial infarction in patients with high cardiovascular risk. So you define also your patient population. And then you may also want to have some sub-aims, whether green apples lower the risk of myocardial infarction in patients with hypertension or with hypercholesterolemia, or you have to take apples for 1 month or for 12 months, or whether green apples only prevent ST elevation or non-ST elevation myocardial infarction. So you really have to define where to prove your hypothesis. And then the question is, how can I answer the research question once I have it? When I have defined my research question, I have to go into these details. I need to think about the study design, about the study population, the exposure, and of course also the endpoint and the follow-up. So the randomized controlled trial is, of course, the gold standard of an interventional trial. This means that you need a control group, which should receive the standard therapy, or if there's no standard therapy, then you need a placebo. And you need a randomized patient, which means it ensures that the treatment groups are only different with regard to the intervention. So just by chance, patients go in one or the other group. And the other way is to do an observational study. So you test the association of a risk factor with an outcome. In a cohort study, you start with a cohort and you wait that an event occurs. If this is a rare event, it does not make sense to make a cohort study. If only 1 in 1,000 of patients get an event within 10 years, don't do a cohort study because you will wait very long and you will not get enough events. In this case, with rare events or with rare disease, you should use a case control study. So you already start with individuals which already have the disease or the event, and you can compare them with a control group which does not have the disease, for example. And for cross-sectional study, that's the third option, you do at the same time, you determine the prevalence of the disease and the risk factors. You may have descriptive aims, like the prevalence of disease, so how many patients over 80 have atrial fibrillation, for example. You may want to see time trends, for example, how many patients take NOACs in 2010, in 2015, for example. And then the other way is that you also want to compare intervention and observational trial. However, this is dangerous and you have to be very careful about because it's prone to bias and confounding. Well, what is bias and confounding? That you always should think when you design and you perform your studies, it's like the enemies of the sound research. Bias means that you have a systematic error that results in a conclusion which is not true. And there are two ways of bias. That's the selection bias, which means that the patient or study procedure are not comparable between the two groups. And the other one is the information bias, that the information is not comparable between the two groups. This could be either the participant who reports differently between the two groups, usually not by purpose, but because he has certain beliefs about the treatment and then think, okay, I have some bleeding, for example, I think it's because of the drug, or it's really a serious bleeding, also it's not serious. So it's just by his belief, it's not by his purpose. And the same may occur for the researcher, so that's the observing bias, that the researcher also thinks differently about events just by his beliefs, not by purpose, but just because he has some beliefs. So this may happen because the researcher and the patient knows what medication he gets. This is bias, and the other thing is confounding. Confounding means you have some relationship between an exposure and the outcome, and this relationship is distorted by a third factor. That's the confounder, that affect the effect of the exposure and the outcome. And there may be positive confounding, so if the confound is present, the effect seems stronger of the exposure, but there may be also negative confounding, that the effect seems weaker, so also the other way may occur. What can we do? Let's start with bias. To avoid bias, in an interventional study, selection bias is avoided by randomization. So if you have correct randomization, it means the groups are comparable. But not only randomization is important, but also what happens afterwards. So patients really need to adhere to the protocol. There should be no crossover, for example, and you really should analyze patients about the intention to treat, so really according to the group they had been randomized to. And with regard to the information bias, if you have double blinding, then it shouldn't be any influence of the beliefs of the researcher or the participant. It gets more difficult in the observational trial. In the observational trial, you can try to avoid selection bias by inclusion-exclusion criteria to make the study population as representative as possible for the source population. Because of course you want to have them to be as similar as possible as the source population, because if you find something, you also want to translate this finding back to your source population. And within the study population, within the two groups in the observational trial, you can try to make them as similar as possible by matching. And with regard to information bias, at least you can make participants unaware of the study aim, and you can try to make researchers classifying endpoints unaware of the exposure of the individual. So here we have an example about matching. This is an observational trial about NOACs, about dabigatran. It was published in 2015, and they did the so-called propensity score matching, which is a usual way to make groups very similar. And they had a good chance to do propensity score matching because what you need is a lot of patients, and they had 134,000 patients, so they had really the chance to find patients between the two groups who were similar. And sorry, I think it's not very large, and I hope you can read, but the important information here in the right column, because here you see the standardized mean difference, and you always say 0.01 or 0.00. So they did a really good job in the study, and they really made these groups very similar. They had actually 67,000 patients in both groups. So they were huge groups, and the groups were very similar with regard to these baseline characteristics. For example, if you look here at the CHUD score, so the thromboembolic risk of patient was 0 to 1 in 28% of patients in both groups, CHUD score of 2 in 40% in both groups, 3 in 21% in both groups, and more than 4 in also in 10 or 11% of both groups. So almost the same percentages in both groups. But, and now there's the huge but, it can only match for known variables, and that's the huge difference. So here they match for really a lot of variables, and they did an excellent job, but still there may be variables we do not know. For example, socioeconomic factors you usually do not know about your patient, so you cannot adjust for this in this matching. And that's the big advantage of the intervention of a randomized controlled trial. Here's a more critical example. It's the platform study. It's published in European Heart, and I'm not too happy about this study. I have to say it's about non-invasive testing using a new method. It's a CT-based method, so computer tomography-based method, and they use the so-called FFR measurement in addition to the usual CT. And they had one group where they had already planned coronary angiography. So patients already were scheduled for angiography, and the other one group where they had planned first to do non-invasive testing. And let's look first in this group for planned non-invasive testing. And if we look here in the group who gets the new method, the FFR-CT guided strategy, patients were sicker, so the patients had a higher BMI, patients had more often hypertension, patients had more often already taken aspirin, and more often they had typical angina. So they put the sicker patients into the new strategy group. Of course, what happens that it's easier to find something. In a high-risk group, you will more often find some differences in the stenosis in the coronaries. And if we move on, they told us they will compare standard assessment by non-invasive testing compared to the new method. And here we see the new group, the CT group, and really all patients of them got a CT. But if we look closely, only 60 patients of these 104 patients got the new method because it didn't work, obviously. So actually, only 60% really got the new method. And was the same for the other group where they already planned coronary angiography. So first they put the sicker patients in the new method group, and then they didn't perform the new method in all patients, but only in about 58 to 60% of patients. And the third thing about the study, which I do not think is a good idea, and you only find it in the supplement, is what did they do for the usual care strategy? And if you look here, the usual care strategy should be that they got a non-invasive testing, a common non-invasive testing, and actually they didn't do any testing at all, so there was no non-invasive testing in 50% of patients, so nothing happened. So what did they do? They put the sicker patient in a new group. They didn't perform the new method in 40% of patients. And the third thing, actually what they compared was computer tomography compared to usual care, which was 50% of patients doing nothing, so no test at all. So we have to be really clear about such data. And this is not a good example how you should perform comparison in an observational trial. And so there's a lot of bias in this study. Well, let's move on to confounding. And here we have an example. These are different European countries, and we have the number of stork breeding pairs, and we have the birth rate. And surprisingly, there's some relationship between the stork breeding pairs and the birth rates for human beings. So is it true that really the stork brings the baby? Well, I think no one really believes, but it looks like. So we have some association between the storks and the birth rate. And the explanation is the land area. So lands with a larger area have more storks because they have more space, and due to socioeconomic reasons they have a higher birth rate. So this is the so-called confounder. And then if we look at this in theory, we have here the exposure, we have here the outcome, but there's no real relationship, but it's confounded by the confounder here. Another example, which is very relevant for us, coffee. And there's the question if coffee causes cardiovascular mortality. And there are some studies showing that coffee may increase the risk. But again, if you do adjustment for relevant confounders, you find that there's no association between coffee and cardiovascular mortality, and the confounders like smoking, which cause this spurious association. Oops. So again, you have an exposure, you have an outcome, but there's no real relationship, but it's the confounder, and usually the confounder is associated with the exposure and has some effect on the outcome. What can we do to prevent confounding? Randomization in the interventional trial avoids all confounders because they should be equally distributed between the two groups, so we shouldn't have any problems with confounding. In an observational trial, we can do adjustment for confounders, so we can avoid the influence of non-confounders, but we cannot avoid the influence of unknown confounders. That's the problem. Let's move to the study population. We need to think about the sample size. That's a really critical question always, because you want to have sufficient power, of course, to show that you do not miss your results because just by play of chance, because you do not have enough power. And on the other side, of course, you have restricted resources, so you cannot say, well, to be sure, let's include 1,000 patients more. And no one has the money to do this and the time to do this. So the way to do this is to do a sample size calculation. And you also have to think about the external validity of your study population. And there's no right or wrong, but you need to think about where you want to go with your results. And for example, it's an important question, is study population representative of the source population? This means that I can translate my results immediately to the general population. So that's a good way, but sometimes I have a different aim. For example, I want to have a high-risk group to ensure a sufficient number of events. So if I want first time to show that the effect, that new treatment is really effective, it's also a good thing to go into a high-risk group because I have enough events. So I really should think, what is the right population for my question? And I could also go in specific subgroups like women, elderly, so who are not equally presented in studies very often. And here we have an example of sample size calculation, and there are two variables which influence the size. It's the difference between the event rate between the two groups. If I want to see only a huge difference in event rate, for example, with a huge hazard ratio of 3, for example, in this case, I only need 500 patients. If I want to see a smaller difference of only an increase of risk of 50%, so one hazard ratio of 1.5, I already need six-fold number of patients, so more than 3,000 patients. So the one thing is, what difference do I want to see? And the other thing is the event rate. If an event rate of 50%, which is very high, for example, for mortality, I only need 350 patients. If I want to see a difference with an event rate of 10%, I already need almost 10-fold number of patients. So this also greatly influences the number I need for my study population. And actually, usually 10% is also very much. So most studies fight with 2, 3, or 4%, and then I need an even higher number of patients. And the important thing is, you never know before the study exactly where you end up. So the good thing or the good way to do it is to do a table like this and try different scenarios. So do not make one sample size calculation, but do 20 sample size calculation, and then you get the feeling what changes about the numbers when the event rate changes, for example, and the difference changes. To really get to know where then you find a compromise where you think, okay, this is a fair chance with this number of patients really to find a difference, if there's a difference, a relevant difference. And of course, believe your sample size calculation. Very often I see sample size calculations and they calculated something, and obviously then they thought, well, I do not have so many patients, so I adjust my sample size calculation to the number of patients I have. Of course, this doesn't make too much sense at the end. So you really have to think what to do if I do not have enough patients. And for example, you have then to think about a multi-center trial if you do not have enough patients. And you also have to take account of loss to follow-up, of course, because you will not end up with the same number of patients at the end of the study. Well, inclusion and exclusion criteria, a topic where again there's no right or wrong how to do it, but you should think what is the right thing to do for my study. If you take very strict inclusion and exclusion criteria, it means you have a very well-defined study population. It makes the effect more predictable, and so you have internal validity. And it's safe, and that usually what happens with new treatments to the exclusion of high-risk patients. If you have new anticoagulation, you do not want to include patients with high bleeding risk, of course, if you have to show the effect of a new treatment for the first time. And on the other side, if you have very strict inclusion and exclusion criteria, it's very difficult to recruit patients. You will not find so many patients who fit, and it increases cost, time of recruitment, the risk of the failure of the study. So you may end up that you cannot finish your study because you do not find the patients for the study. And of course, if you have very broad inclusion exclusion criteria, it increases the external validity, so you really can translate your study, the results to the general population, and of course it facilitates the recruitment of patients. So you really should take a lot of efforts and thoughts into this topic because it will very much influence your study. And of course, already the selection of the study site restricts patient selection. So if you're a university center, you do not see the typical patient, you see a very highly selected portion of patients. And here we have an example that's from the RELA trial, testing dabigatran compared to vitamin K antagonists for patients with atrial fibrillation. And sorry, it's very small, But the main message from this slide and the next one is you had 14 classes of exclusion criteria. So they really wanted to be careful, and it's not typical for this study, it was the same for all of these studies, that they really wanted to exclude patients at high risk, of course, because when they first wanted to test a new study, they wanted to be safe. So for example, if you go to class 3, conditions associated with increased risk of bleeding, there was major surgery within the previous month, planned surgery, history of intracranial and other bleeding. So they really tried to exclude high-risk patients. That's fine, but then still we have to think, can we translate these results of the studies to the general population, because these patients were excluded in clinical practice. We see these patients, of course. And here we see the continuation of the 14 classes of exclusion criteria. Another example, the Jupiter trial. In the Jupiter trial, they had to screen 90,000 patients to find 17,000 patients, so they really had to do huge screening because they only wanted to see or include patients who had a low cholesterol and a high sensitive C-reactive protein, because they wanted to test instead in patients who do not have hypercholesterolemia but who have high inflammation. And they ended up excluding 52% of patients because they had high LDL cholesterol, and excluded 36% of patients because they had low C-reactive protein. So as I said, they ended up with 17,000 patients. And of course the question is, after they got the results, for which patient can you translate these results? It's not for the general population, of course. It's only for the 17% or 19% or 20% of patients where you can really use these results. And of course, they had a huge effort to include these patients also. When you want to answer your research question, you also have to think about the exposure. This can be a standardized intervention like pharmacotherapy. That's the easiest way. You have a dose, you have a duration. It's easy to standardize and define the exposure. It gets more difficult with biologic measurements, for example, radiation. You need some standardized measurement of this biologic measurement. And the worst thing to do is to do an assessment of history of beliefs, because then you need standardized questionnaires, interviews, which is very tricky. So this is an own field of investigation, how to do these questionnaires, interviews correct. So we are fine to use cardiovascular pharmacotherapy. Is an easy way to do, but be careful if you go into the other fields. You also have to think about your endpoint. For example, your clinical endpoint. If you have a clinical endpoint, of course, that's the best way. For example, cardiovascular mortality is a specific endpoint. It's more reliable, but the problem is it may be rare. So if you have not enough endpoints, one way is to use surrogate endpoints, for example, blood pressure. But then you have to, and the advantage is you need a smaller sample size only, but then you have really to be aware, is the surrogate endpoint a valid measure of the ultimate clinical endpoint? If you are not sure that there's really a close relationship between your surrogate endpoint and your clinical endpoint, it doesn't make sense to use the surrogate endpoint. You of course have to think about your follow-up, how you follow up the patients, about the duration. If you're longer duration, of course you have more endpoints. Many modern studies now have an endpoint-driven follow-up, so they wait until a certain number of endpoints occur and then they stop the study. And if you have shorter follow-up, eventually you have a closer association between the initial intervention and the endpoint, of course. And then, after you have thought about all the things and how to design your study, you also have to think, what things do I need to perform the clinical study? That's a study protocol, of course. You have to think about your data acquisition, about your statistics, about funding, about your study site, about ethics. You need to register your study, and you should also think about study reporting. We'll discuss all the things where you find an asterisk in other sessions, and I will go through the points where there's no asterisk now. The study protocol is very important. You should always have a study protocol and like your schedule for your study. So you should really also follow your study protocol. It doesn't make sense to have a study protocol and never look at the study protocol anymore. It should have some contents, of course, a title, an author, The author should be on it, the rationale, the research question, study design, study location, the study population, as we have discussed now, definitions of exposure and outcome, statistical analysis, but you also need to think about technical things like data acquisition, about the study flow and logistics. What is the aim of the data acquisition? Of course, to have a complete, correct, and standardized recording of key data. Which information do you usually need? You need your exposure, of course, you need your endpoint, and you also need to assess your confounders. And there may be different sources. This may data forms for, and you need the data forms for standardized data acquisition with coded answers always, so you already can easily translate them into the computer or already assess them with a computer program. You have to think about questionnaires, and you have to be really very careful about these questionnaires. They should be predefined questions and answers to minimize bias, so the participants should not be triggered in one direction just by giving them some predefined answers. You should be really balanced, so they really express their own opinion, and you should of course encourage complete data acquisition and should be validated. And also biometric measurements may have some measurement errors, so you have to be aware of inter and intra-assay variability, for example. And you always should think also at the beginning also already about the transfer into databases. Some general statistical considerations will go into detail in later sessions. First, what is the gold standard? And there are some reporting standards like the consult statement. But if you're a specific field, you also should already look at the beginning at the instruction for authors of journals. For example, if you want to publish genetic studies, they have very specific requirements, the journals, and because they were very difficult topics in publishing and in replicating results, so journals got very cautious with the studies, so they have very specific requirements. So if you want to finally publish your results, it's very good already at the beginning of your study to look what are the requirements of the journals. You should have to think about of course, your descriptive statistics, and then about your analysis of relationship between exposure and outcome. You have to think, do you think you see a causal relationship or not? And then decide which test you use. You should think if I need a univariate analysis or multivariate analysis, which mean I already include confounders if you want to have a time-dependent or independent analysis. Usually, very often now, time-dependent analysis is used. And if you do an observational trial, very often now the journals require you to use an external validation. So you already, if you want to look at biomarkers, for example, and you find an association with your biomarker in one study group, you also should think where can I validate in another independent cohort these results, because the editors very often will ask you to do an external validation. And you should also think which patient should be analyzed at this stage. So do you do on treatment, intention to treat? We will come to this later on. You should think about your resources. To have sufficient number of patients, as I said, if you do not have sufficient number of patients, you have to think about another way, which may be a multi-center trial. To have really sufficient personnel with dedicated time. So at the beginning, usually everyone is very enthusiastic, but you also have to think about 1 year later on if you still have enough dedicated personnel really to perform the study on the long term. To have sufficient financial resources, of course, and to have the resources for the whole study period. You need to register your study. If you do an interventional trial, you can do this, for example, clinicaltrials.gov or WHO website. Why do we need this? We need to do this because we avoid publication bias. So because we are afraid that negative results are never published. If studies need to be registered before, then we also see which studies have been performed and have not been published. And also to predefine your analysis, to prevent phishing afterwards. So if you do, for example, subgroup analysis, you really should define before starting your study what subgroup analysis you want to perform. Because afterwards, then everyone thinks, okay, they just looked at the database and found some association afterwards, and then they said, oh, that's interesting. but it should be like you have an idea, you should tell that you have the idea and then make the analysis according to the idea. So let me summarize. Before you start the adventure of a clinical trial, you should challenge your idea, not just go by just one brainstorming and start, but really challenge the idea, ask other people, look in literature, check your resources, think about, do you have really all the means to perform the study? And of course, the human beings, the researchers, the most important resource you need. You need your study team, but you also need your money, of course. And do you have really the adequate expertise? So don't go into a large study when no one will believe you the results because you're the newcomer in this field. And always have a study protocol, of course, also follow the study protocol. Thank you for your attention.